Hello everyone, welcome back to the channel. So today we'll be starting with the part 2 of High Yield Orthopaedics and Rheumatology series for AMC part 1 examination. And if you haven't seen the first video yet, make sure you check it out. We have covered some topics like acute compartment syndrome, ankylosing spondylitis and clavicular fracture in that video. So for today's video I have planned topics like muscular dystrophy, in which we'll discuss Becker's and Duchenne muscular dystrophy, and then gout and pseudogout. We have developmental dysplasia of hip, Perthes disease and slipped capital femoral epiphysis, also known as SCFE. So these are most commonly asked disorders in orthopedic. Along with that, pedia integration is there. Okay, now starting with Duchenne muscular dystrophy, that is DMD. So first thing is it is an X-linked recessive disorder that we have to remember. And then the next thing is that there is a deletion, that is the frame shift deletion is there, also known as nonsense mutation, which results in truncated or absent dystrophin proteins, which can lead to progressive myofiber damage. And basically this forms the core reason for there is an important sign associated with this disease, that is Gover sign. I have also attached the photo of Gover sign here. When we are talking about the clinical presentation of the patient, there would be progressive muscle paresis and atrophy. Also there would be weak reflexes, there would be waddling gait, Gover maneuver would be there, which is 3 to 4 step process by which a kid gets up. Pseudohypertrophy can be seen. Now looking at the cardiac and respiratory muscle involvement, there could be dilated cardiomyopathy, and also it is the most common cause of death in children with Duchenne muscular dystrophy, and mental retardation is also common. So this is the calf pseudohypertrophy that I was talking about, and this whole 5 photos are the steps that are involved in Gover sign. Then for the investigations, we would do blood test in which we'll be able to see creatine kinase level would be elevated, and along with that aldolase level would be elevated, but that is not important for AMC. And for the confirmatory test, we'll do genetic analysis. On that we'll detect dystrophin gene mutation if it is present or not, and if this test is inconclusive, then we'll do muscle biopsy for the diagnosis of muscular dystrophy, Duchenne muscular dystrophy. The only thing that we need to know about Becker is better, because in Becker there is no frame shift deletion. It is a non-frame shift deletion, so that the dystrophin protein is not completely absent, but it is partially functional in these patients. Then we have gout. So gout, I am dividing it on 2 bases. First is primary gout, and the second one is secondary gout, also known as hyperuricemia. So primary is idiopathic. Secondary, it can be because of some drugs like diuretics, aspirin, niacinamide or pyrazinamide, and high alcohol consumption is one of the important trigger for flare-ups. And along with that, Leishman syndrome, that is HGPRT deficiency, that is the link from biochemistry. It is also important, and tumor lysis syndrome, also known as rhabdomyolysis. These are some of the important etiologies for gout. Then when we are talking about the acute presentation of gout, it includes, most important thing is podagra. It is happening on the first MTP joint of foot, and it is also the most common site for it. It can also affect knee and cause knee inflammation, or it can also affect finger joints. So these are the common sites for acute presentations. Then when we are talking about the chronic gout, so mostly it can cause tophaceous gout, that is tophies. Also renal manifestations can be seen like nephrolithiasis or nephropathy. So these are the features that are present in chronic gout. Now when we are talking about the diagnosis for gout, the gold standard, the most important thing, it's AMC's favorite question: how will you diagnose gout and what will you see after that? So for diagnosis, arthrocentesis with synovial fluid aspiration analysis is the most important diagnostic manifestation. And then what will you see? Needle shaped monosodium urate crystals that are present on negative birefringence, and along with that hyperuricemia, you'll be able to see the urea levels would be elevated, and on x-ray you'll be able to see punched out lytic lesions. This is different from sclerotic lesions. This is lytic lesions that are diagnostic for gout. Then when we are talking about the treatment, so first line is non-pharmacological, that is lifestyle modification is very much important. Then when we are switching to the pharmacological therapies, if the patient is presenting to you within 24 hours, then it has to be NSAIDs or colchicine for mostly analgesics. That is important that it is the first line of choice and the patient should be present within 24 hours. And if the patient is having renal impairment, then steroids is our only choice. Also, oral prednisolone we have to give. And if the patient is not able to tolerate oral prednisolone, then we can switch it to intra-articular steroids for the pain. Then treatment for chronic gout would be urate lowering therapies. First line would be xanthine oxidase inhibitors, that is allopurinol, and probenecids we can use, febuxostat, pegloticase. These are few of the drugs that can be used in chronic gout. Next topic is pseudogout. It is very much similar to gout. There are crystals different from gout. Most common question that AMC asked, and this is the question that is being asked in June 2025 recall. So what are the crystals made up of? So the answer for it was calcium pyrophosphate dihydrate or CPPD crystals that is found in the articular cartilage, and it can lead to inflammatory arthritis, that is also known as crystalline arthritis. Now what are the risk factors that are associated with pseudogout? The age has to be more than 70, and the family history of pseudogout is very much important. Along with that, hyperparathyroid or hypercalcemia, these are also the risk factors for pseudogout. Now talking about the clinical presentation of the patient, so similar to that of gout, we have acute arthritis and we have chronic arthritis. So in acute arthritis, it mostly affects the knee joint and the wrist, and in the chronic arthritis there are different types, but then that is not important for AMC. Now when we are talking about the diagnosis, it is similar to that of gout. The same thing we are doing, arthrocentesis with synovial fluid analysis, but the only difference is there we had needle shaped, here we have rhomboid shaped crystals that are weakly positively birefringent, and these crystals are made up of CPPD material. That's it. And when we are doing the x-ray, we'll be able to see chondrocalcinosis. Yes, this is important. Now when we are talking about the treatment for pseudogout, it would be intra-articular injections of glucocorticoids. It is the best thing. Then after that you can use colchicine. Then after that you can use NSAIDs or systemic glucocorticoids you can use. But for the prophylaxis of pseudogout, low dose colchicine is important, and then you have to remember this because they can ask it like this: what is the medication that is being used for prophylaxis of pseudogout? So then you have to answer low dose colchicine. That's it for pseudogout and gout. Just make sure that you see all the x-rays that are associated with these two conditions and how does this positive negative birefringent looks like. Now the next topic is developmental dysplasia of hip. It is also again very much important because of the pediatric and orthopedic association of this topic. Now family history is very much important for developmental dysplasia of hip, along with breech presentation of the child. Now for this whole topic, I know that there are too much information that is being given about this topic, so I'm going to give you a short table sort of thing. That thing only you have to remember for AMC, and that's it for this topic. So we'll divide this table in 3 points. So one is less than 6 months, then we have 6 to 18 months, and then we have more than 18 months. So first thing is, how will you diagnose if the baby is having DDH or not? So in the baby in the time frame of less than 6 months, Barlow or Ortolani test we are doing. So first photo is Barlow test and the second photo is Ortolani test. So you can watch videos on YouTube how this is being performed. Then for the investigation of this age frame, we are using hip ultrasound. And then for the treatment of this time frame, we are using Pavlik harness, and I have attached a photo of it. Yes, this is the photo. That is Pavlik harness. This is for less than 6 months. Then we have 16 to 18 months. For this, the features would be inability to abduct the legs. Then there could be Galeazia sign, or there could be gluteal folds that are asymmetric. So these are two of the features that are being present in 6 to 18 months period. You can watch the photos, but it is not that important that you remember the photos for this. Mostly they are asking about if the child is present in this age frame, what will be the diagnosis or what will be the treatment for it. So for this 6 to 18 months, the treatment would be closed reduction using a hip spica cast, and for the investigation for both 6 to 18 and more than 18, we are using pelvic x-rays. Only time we are using hip ultrasound is less than 6 months. That's it. Now for more than 18 months, the symptoms would be leg length discrepancy would be there, and pelvic tilt would be there, and waddling gait for the baby. And for this stage, we have to do surgery therapy, and the definitive treatment is open reduction. We'll have to do surgery, and that's the only treatment for DDH. That is after 18 months. That's it for this topic. Then we have Perthes disease. So most commonly it is idiopathic. But then what is the exact pathophysiology for it? It is the avascular necrosis of femoral head. Also it can cause painless limb, rarely, but then hip pain is seen on weight bearing on that particular limb. It could be unilateral, it could be bilateral. So these are the common presentations. But then yes, it is important that you focus on the age frame for Perthes disease. It is 4 to 8 years of child, and it can project on the ipsilateral knee, as the pain can progress from the femoral head to the knee. Now when we are talking about the clinical presentation, yes, hip pain would be there on weight bearing. This is one of the most important features that we can see in this patient. Next is on Faber test, the pain would be there. That's it for the clinical presentation of the patient with Perthes disease. Now when we are talking about the diagnosis of Perthes disease, so it is divided into early phase and late phase. For early phases of Perthes disease, MRI is what we are doing, but for the later parts of the disease, we are doing X-ray. Now for the treatment, there should be reduced weight bearing on the affected side, and along with that, bed rest is usually adequate. But if the Perthes disease condition is a bit severe, then surgery is the only option, and femoral osteotomy is what we are doing. And in this stage, we'll have to refer the patient to orthopedic surgeon. That's it for Perthes disease. Next is slipped capital femoral epiphysis, also known as SCFE. It is the most common hip disorder in adolescent period. The proximal and inferior displacement of the femoral head is most common in relation to the femoral neck. Now for the risk factors, obesity, extreme weight in children is very much problematic and can lead to SCFE. And along with that, family history, if it is positive, then it is also associated with SCFE. Now when we are talking about the clinical presentation, there could be dull pain in the medial thigh, knee or groin, and often it is mostly seen in the left side. rather than the right side. And there would be restricted range of motion in almost all the directions, but it is most especially seen in internal rotation. For the diagnosis, there is a specific position, that is frog lateral view, that we can use, and for the treatment there has to be percutaneous pin fixation of that particular joint, and then the baby would be settled after a period of time. That's it for the treatment. And also, because it is caused due to obesity, so weight reduction could be helpful.